So I'll briefly touch upon a couple of these trials which are very important, and then take on what we can take for our clinical practice. So primary angle closure disease is a spectrum. We know that the first stage is PACS, then it goes to PAC and a PACG, and you have an acute primary angle closure as well. Now question is, do we treat all of them similarly? Not really, because the primary angle closure and primary angle closure disease definitely needs to be treated, where studies have shown that doing a laser peripheral iridotomy by relieving the pupillary block can decrease the progression by about close to 30%. And from PACS to PAC, over 5 years, maybe 22% of the people can be reduced from converting to PAC over 5 years. So which means that the number of people that you need to treat with PAC to prevent it from developing a primary angle closure glaucoma is quite high. So there are various guidelines, and each one of them tells different things, but there is no particular guideline that we follow. In our country, we realize that there are many centers, even major centers, who've been advocating PI for PACS as well. So there is evidence today to say whether that is necessary or not. So this was the study that was ZAP trial published in the Lancet. From Gonzau Center, 6-year RCT, where they included people 50 to 70-year-olds with only primary angle closure suspect, and one eye was treated and the contralateral eye was used as a control. And that was a very significant one, and they were followed up for 6 years, and their primary endpoints was elevation in intraocular pressure, with or without dilatation, of course, they looked at, but also with dilatation, because that was a significant factor. More than 1 clock hour of peripheral anterior synechial development or episode of acute angle closure. What did they find? Without dilatation, only 2 eyes developed acute angle closure, and the rest were with dilatation. So that were 3 eyes with dilatation. And intraocular pressure more than 24 millimeters of mercury in the control group. That means no laser group was in 5 eyes, and post-laser was in 3 eyes, and peripheral anterior synechiae developed in 15 and 30 eyes respectively in both the control and in the laser peripheral iridotomy group. So what does this actually mean to us? It means that there was an absolute risk reduction over 6 years of 2.28% and a relative risk reduction of 47%. That means you need to treat at least 44 patients to be able to prevent one PACS from developing one of the changes of PAC. So I don't think that was necessary. That is necessary for us because the number of people that you need to treat will be significantly more. So what do we take home from this is that LPI is not recommended in every PACS, but there are certain risk factors that we need to consider where there are symptomatic patients with a headache or family history of glaucoma with a disc at risk, a small disc, repeated dilatations if they require because of a retinal pathology, or they come from remote rural areas who cannot travel, they possibly can be treated. Has it changed our practice? To some extent, yes, but we do have evidence to say we should not be doing a PI in PACS unless it is at high-risk eyes. The second study, this was something that I was very excited reading this because I think I will change my practice pattern based on what I have understood from this study. So this study is LiGHT trial, which is the selective laser trabeculoplasty versus drops as first-line treatment for ocular hypertension and glaucoma. So typically we use medications, and if they don't work, we may go in for laser in open angle I'm talking about, if not surgery. And laser is not something that we consider typically as a first-line treatment for our patients, at least most of us. So we know that there are problems with eye drops, and the major problem apart from the side effects and the cost and things like that is the compliance or forgetfulness. It's not easy to comply with this medication. Chronic use of any medication will be very, very difficult. So what has the study looked at? It looked at comparing drops versus SLT as the first-line treatment for ocular hypertension and POAG, and compared the cost effectiveness as well as the compliance in these two studies. So we know SLT, I'm not going to the mechanisms, but basically what it does is because of the mechanical as well as the biological changes that it causes, it increases the outflow in patients with open angle glaucoma. They looked at the health-related quality of life as well as looked at the cost and the tolerability of the medications done across various centers in the UK. Inclusion was all patients with untreated POAG or ocular hypertension. Remember, they did not have medications at all to begin with. So they were treatment-naive patients who were older older than 18 years of age. They did not include advanced glaucomas, mild or moderate, or ocular hypertension. It was a huge trial, and they had two arms. First arm was laser first, and the second arm was the medications first. In the laser first group, if they did not respond to the first laser, then they would go on to retreatment with an SLT, that is the second laser. If not, then they would go on to add medications. Whereas in the medications group, the first line was medications, the second line was also medications, and if that did not work, they did not offer SLT, but they went on to doing the surgery or the trabeculectomy. So these were the group of patients, but what was interesting and what was also nice, and possibly we would do that in our practice as well, as was the amount of IOP reduction that you would expect in a mild, moderate, and severe disease. So severe disease, of course, they did not include, but the end point was also different across for ocular hypertension as well as for POAG. They did not find much difference in the health-related quality of life between the two groups, and one of the reasons that the authors had quoted was that none of these patients, when in the laser group, had medications prior, and hence they do not know whether there was any problem with using long-term medications, whether it was the side effects with the topical medications or difficulty in remembering to use the medications. They were not aware. So to begin with, they were offered laser, and to begin with, they were offered treatment. So they were not switched, hence they did not know the benefit or the side effects of the other arm. Possibly that's why they did not find much of a difference, is what they have told. And as regards to the control of the disease, the first panel here is for the medications group, and the second one is for the laser group. The treatment escalations were a little bit more for the medications group, as was expected. Disease progression was a little bit more in the medications group compared to the laser group. Trabeculectomy was required because, again, remember the way the study was designed, trabeculectomy was required in 11 eyes, and trabeculectomy revision was required in 5 eyes. And none in the laser group required trabeculectomy, because if the laser did not work, the second laser, if that did not work, they went on to use the medications. And there was not much of a difference between the intraocular pressure as well as the visual acuity in the two groups. So at 3 years, they found 78% had followed up, 74% of the patients were drop-free at target IOP in the SLT group, and 77% of the eyes controlled with one single SLT and did not require an escalation. What was also very interesting to see was only one patient had an IOP spike among those eyes that underwent a laser. So what is the take home for me? SLT should be considered or can be considered as first-line treatment or can be offered to our patients for ocular hypertension and early or moderate glaucoma. And one thing we need to remember, even if somebody asks me, I would say that, I'm worried to give this as an option because they may not come back for follow-up. But whether it is laser or medications, they have to come back for follow-up. So I don't have much time for MIGS, but I would just move on to say that MIGS is something that we have been doing now, both in open angle as well as angle closure. And one point I would just like to highlight, if you give me 30 seconds, is the way we look at the MIGS publications today. So there is no standardized protocol that we follow. Each person gives a different way of, because they are on medications, we are looking at number of medications drop, amount of IOP drop, as well as the percentage of IOP drop. And there has been no uniformity. I think moving forward, we have to look at all of these with regards to the guidelines, at least a 2-year follow-up with a reduction of at least 20%, and based on the severity of the disease, the percentage reduction also is something that we need to look at. And has it changed my practice both in open angle as well as in certain types of angle closure glaucoma? I would say that MIGS are here, whether as a single procedure or combined with cataract extraction, they do have a good promise. But like I said, we have to individualize it and use it as per our understanding and look at not just pressure control, number of medications, but long-term intraocular pressure control and visual field changes.